Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Use and Effectiveness of Intraperitoneal Chemotherapy for Ovarian Cancer by Alexi A. Wright et al. My name is Deborah Armstrong, and I am Professor of Oncology and of Gynecology and Obstetrics at the Johns Hopkins Kimmel Cancer Center in Baltimore, Maryland. My oncologic specialty is medical oncology. 3 randomized phase 3 trials have documented a survival benefit for the use of combined IV-IP therapy as initial treatment for optimally debulked stage 3 ovarian cancer. In spite of this, IP therapy has not been universally embraced as the standard of care in this population. There are likely multiple reasons for the improved outcomes with the use of IV-IP therapy compared to IV therapy. The most obvious and best studied is the pharmacologic advantage for active anti-cancer agents administered intraperitoneally. Drugs administered IP are initially delivered in a large volume, usually 1 to 2 liters. However, the fluid is absorbed quickly, and the resultant concentration of the drug will be much higher than can be obtained when the same drug is given intravenously, resulting in peritoneal concentrations that are 20 to 1,000-fold higher than systemic concentrations. Paclitaxel is a large and insoluble drug with little absorption and minimal systemic exposure after IP administration, and active intact drug has been documented from peritoneal washings 1 week after IP administration. About 70% of IP-administered cisplatin will be absorbed and available systemically. However, the slow absorption from the peritoneal cavity results in a lower peak plasma level, but a more prolonged exposure, and a toxicity profile that differs from what is seen when the same dose is administered intravenously. This paper by Wright and colleagues is a prospective examination into the use of IV-IP therapy at 6 NCCN institutions, and importantly documents variability in regimens, treatment toxicity, completion rates, and survival. They found that overall 41% of eligible patients received IP-IV chemotherapy. The use varied significantly by institution, ranging from 4 to 67%, suggesting that the provision of IP-IV chemotherapy may be influenced by the local institutional culture and the enthusiasm of practitioners for this treatment. And while acknowledging that patient preference is a critical element in treatment selection, research into patient choice has clearly documented that the single most critical element is the enthusiasm of the treating physician. The authors also show that patients who are younger and those with fewer comorbidities more often received IP-IV versus IV chemotherapy. These factors are not unique to ovarian cancer and are documented variables predicting receipt of and completion of recommended consensus treatments across the oncology disease spectrum. Among patients receiving IP-IV chemotherapy, 29% received the GOG 172 regimen without modification, 28% were enrolled in clinical trials, and 43% received modified regimens at treatment initiation. Modified regimens commonly involved reductions in the dose of IP cisplatin or an IV drug substitution, such as docetaxel for paclitaxel. Although not reported in this paper, it is expected that most of the modified regimens and the trial regimens allowed for outpatient administration rather than requiring inpatient hospitalization, which simplifies treatment and reduces costs and patient inconvenience. It is clear that when platinum agents are used intravenously for treatment of ovarian cancer, carboplatin is the preferred platinum agent, as it provides equivalent efficacy and improved tolerability with less toxicity. The first randomized phase 3 trial with an arm using IP carboplatin, GOG 252, has completed accrual and is in follow-up. Thus, while IP carboplatin is not currently considered a standard for IP platinum administration, the results of GOG 252 may provide data in support of carboplatin using the IP route as well. The Wright study reported that women treated with IP-IV chemotherapy received a median of 5 IV-IP cycles and were more likely to switch chemotherapy routes due to treatment-related toxicities compared to women treated with IV chemotherapy. However, it was reassuring that their adjuvant chemotherapy completion rates were similar, 89% for IP-IV chemotherapy compared to 91% for IV chemotherapy. IP therapy as used in GOG 172 had substantial toxicities. The regimen was designed to provide an intensive therapy that cannot be delivered intravenously. However, it has been our experience that when the entire healthcare team is dedicated to IP therapy and is willing to provide the necessary support, most oncology practices are able to administer IP therapy effectively and safely. Wright and colleagues document that there are multiple variations in the regimen administered, and in fact, the NCI consensus statement on use of IP therapy did not recommend a specific IP regimen, leaving treating physicians to decide which IP regimen they should choose when treating their patients. It is clear, however, that whichever regimen is chosen, familiarity with the regimen, with the IP catheters, and with the anticipated toxicities predictably led to improved ability to deliver IP therapy with decreased toxicity. The lack of a clear consensus on which regimen to use should not dissuade treating physicians from utilizing IP therapy any more than it does when there are multiple IV regimens that can be recommended. Data from patients treated with IV-IP therapy in this report did not document the higher rates of neuropathy, dehydration, or infections that were reported in GOG 172. This is particularly significant since IV therapy was likely to have been predominantly carboplatin rather than cisplatin that was used in GOG 172. This improvement in the toxicity profile with IP therapy is likely due to the flexibility of providers to modify the IP-IV regimens to reduce toxicities. In the years since the first patients were treated on GOG 172, there have been significant improvements in supportive care, including more effective antiemetics and optimization of the use of hematopoietic growth factors. In addition, those experienced with IV-IP therapy recognize the importance of additional hydrations, electrolyte supplementation, and IV antiemetics between treatment days for some patients. The magnitude of the survival benefit associated with IP-IV chemotherapy reported in this study is similar to results from prior randomized clinical trials. The 3-year overall survival for IP-IV chemotherapy was 81% compared to 71% for IV chemotherapy. The hazard ratio for death in the IP-IV group versus IV group was 0.68, comparable to the 0.76 in GOG 114 and 0.75 in GOG 172. This report is the first prospective multi-institutional comparative effectiveness study to demonstrate that IP-IV chemotherapy is associated with significantly improved survival among women with optimally debulked stage 3 ovarian cancer outside of a clinical trial. As the authors point out, their results are more generalizable than outcomes from clinical trial, which represent a highly select population, but is likely not representative of clinical practice outside of academic institutions, since the 6 sites are high-volume teaching hospitals. This is confirmed by recent publications indicating that the use of IP therapy for treatment of ovarian cancer is less than 20% in a community setting and a meager 3.5% from the SEER Medicare database. The confirmation of the benefits of IP therapy documented in this paper must serve as a strong reminder to healthcare providers that this remains the standard of care for this population. Rational modifications to the dose and schedule of IP regimens now allow more patients to complete therapy with less toxicity while maintaining the survival benefits. We can have no more excuses why we don't offer this treatment to our patients. Ovarian cancer patients deserve the best treatment we have, and today that treatment must include IP therapy. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.